everyone. Welcome to a really exciting conversation that I'm having with Casey Paleos, a gentleman that I met a while ago in New York, and want to talk about that story. And one of our teachers in Vital, so this is a Vital Psychedelic Conversation. So we're going to get vital, Casey. How are you doing today?
I am doing well, David. It's great to be here. Thank you for inviting me.
Yeah. I've been really looking forward to this conversation, and it's been awesome getting to know you the last year. Wonderful having you teaching our Vital students. And I just wanted to start off by taking a breath and remembering how we first met. So this was about a year ago
Yeah,
at the
almost.
Explorations in Consciousness, Death, Psychedelics and Mystical Experience conference in New York.
Yeah,
And
almost exactly. Yeah, June 8th of.
yeah, and I think I just said, hello, Casey, I'm David Drapkin. And then
Yeah,
we went and had lunch together and hung out in the evening with my wife at the Psychedelic Assembly in Manhattan. And yeah, it was just filled with synchronicity and that this kind of air of it was meant to be. So I just wanted to
yeah.
kind of name it and honor that.
Yes, it was. That was a pretty magical day and evening. Ended up. That was the first time I had visited that building, and ended up within about a couple months after that, renting out a clinic space on the fourth floor of that building, where the Psychedelic Assembly is located, where I've been practicing ketamine infusion treatments and ketamine assisted psychotherapy uh, since August of last year, and that was a direct result of that fortuitous meeting. A lot of other synchronicities we could get into. Probably don't have time to in this venue, but yeah, that was really fun, and just kind of a lovely way to get to know you and your wife Faggy, um, and yeah, it's been really great getting to know you, getting to work with Vital, being invited as an instructor in the Vital program that you guys do through Psychedelics today. It's been an honor and really fun as well. And it's great to be here today talking a little bit more
Yeah.
about this stuff.
Yeah, thanks, Casey. And I recognized you at this conference because you've been around for quite a while, in the psychedelic world. So that's how I knew who you were. And um, for folks that maybe don't know you that well, can you just give a little introduction to yourself and to kind of your role and work in the psychedelic world?
Sure. Yeah, I'd be happy to. So my name is Dr. Casey Paleos. I am a psychiatrist, a researcher in psychedelic assisted therapies for mental health indications, dating back to going back almost 15 years ago now. Was still in residency at NYU in the psychiatry department there when the psilocybin cancer anxiety study started, and I was very fortunate to be involved in that as a study therapist, which is how I got my first exposure into psychedelics for mental health indications, which was totally transformative and really profoundly changed the trajectory of my career. Um, and we'll get into this a little bit later, but were it not for psychedelic assisted therapies, I don't think I would probably still be practicing psychiatry for reasons I can get into. I think we should get into a little bit later, but I stayed on at NYU for a number of years after that as faculty, working in the consult liaison department and in the emergency department. Steve Ross and I were co-principal investigators on a ketamine for depression study that we did in the emergency department at NYU in Bellevue, and that's how I first started seeing ketamine used in clinical practice for depression. And not long thereafter, I started using it in my private practice. So I've been doing ketamine-assisted therapies since around 2016. And in that same year, end of 2016, early 2017, I started getting involved with MAPS in what ended up becoming the phase 3 clinical trials that I served as a study therapist for and as a principal investigator for one of around a dozen sites in the United States. There were 2 sites in New York City, and I was the principal investigator of one of them, the private practice site. So oversaw the work of about a dozen therapists. We saw roughly 20 participants across those 2 clinical trials for MDMA-assisted therapy. So I was very lucky to be involved as a study therapist there and as a principal investigator, and got to contribute to that work, which drew to a close in middle of last year, around June of 2023 for us. And along the way, I also started with some involvement in some psychedelic medicine startups. I was involved in the early days of Mind Bloom. No longer affiliated with them, but did help them get started, help design sort of first iteration of their clinical protocol, which has since evolved a lot, but started, helped them get started, and also helped Journey Clinical get started, was involved in the design of their clinical protocol, and no longer affiliated with them either. Essentially transitioned out of those roles in order to focus on what I'm doing now, which is trying to build a psychedelic assisted therapy clinic and training institution focused on practicum training, giving experiential training, on-the-job training to therapists through the delivery of psychedelic assisted therapies. Right now, ketamine, and if MDMA assisted therapy receives approval in August, or maybe shortly thereafter, depending on what happens, when FDA issues its decision in August, we'll be one of the first few clinics, hopefully, in a position to offer that modality. And we aim to be delivering a lot of practicum training through that, and would also want to continue doing clinical research using various psychedelic assisted modalities, psychedelic assisted psychotherapies. So in order to do that, some colleagues of mine from the MDMA study, principally Dr. Willa Hall, and I have co-founded a nonprofit called Nautilus Sanctuary, which will be working closely with this other company that I've recently co-founded, called Innermost Public Benefit Corp. So the mission with Innermost will be to create an organizational culture that is really centered around sustainably providing this treatment with a high level of integrity and a high level of ethics, which really comes down to the ways in which therapists are being trained and taken care of, and how they're taking care of themselves, and how we are taking care of and relating to our patients, really steeped in what I perceive to be the sort of core values of psychedelic medicine, which is really about patient empowerment and patient autonomy, and allowing a person to engage with the suffering that is bringing them into a situation where they're seeking help from a clinic, creating the conditions that will enable them to find the capacity to heal within themselves. It's really, I feel very strongly about that, and that we'll touch on, I'm sure, a little bit later on when we get into this idea of the inner healer, or the inner healing intelligence, which is the subject, as you know, that I taught in the Vital course. So I'm sure we'll get into that a little bit later. So that's sort of where I'm at right now, is really kind of trying to create an organization with Innermost and Nautilus to deliver these treatments in a way that is high quality and ethical and accessible. And that's, it's a tough riddle to solve, but I think with the right people, with the right intentions, working hard and with determination and perseverance, I think we can accomplish a lot. So it's an ambitious goal, but that's where my energies are focused at the moment. Plus teaching, as mentioned, I've been teaching with you guys. I do a fair amount of teaching with Fluence. I'm certified as a supervisor in the MDMA assisted therapy through Lycos. So, if and when that starts to become commercially available, I'll be doing a lot more of that. And we'll be doing obviously a lot of that within Innermost if we're delivering MDMA assisted therapy, both to certify new therapists and also importantly to offer ongoing continuing education and supervision, and public education too. So I'm very passionate around that piece as well.
Awesome. Casey, you're a busy man, it sounds
Yeah.
like, and there's so many different things there that you're interested in that we're hopefully going to have time to talk about. And you said determination and perseverance are kind of part of the job. And I think working in this sector right now, at least, we need a lot of that and other things. Because it's a vital psychedelic conversation, we always start off with the same question. So it might be something you've already mentioned perhaps, but just to start our conversation off in that direction, what for you feels like one of the most vital things that we should be talking about right now in regards to psychedelic therapy, healing, medicine, and scaling? Where should we start?
Yeah, well, I mean, obviously very active in the field right now, and in my mind personally is the sort of the aftermath. We're all feeling the repercussions of the FDA's advisory committee panel meeting that happened about a month ago, and the repercussions of that, as everyone listening to this I'm sure knows, that panel voted pretty resoundingly to recommend not approving MDMA assisted therapy, or recommending that FDA withhold approval for it. And so I want to speak a bit to that, and mainly around the concerns that were voiced around the psychotherapeutic modality itself, which I think it's very important to disambiguate. I think there's certainly valid concerns that are being raised, but I think there's also a lot of misconceptions around it that I would like to take the opportunity to disambiguate if I can, and just clarify, as someone who has been doing this work for a long time and also involved in training and supervising this work. I mean, I could speak through a lot of firsthand experience of what it actually is that we do in at least in the phase 3 clinical trials, what we did using MDMA, what MDMA assisted therapy actually looks like, and what it should look like at any rate. And also just to speak to the idea that, more generally, whether we're talking about MDMA or psilocybin or another psychedelic, I feel very strongly that, these medicines, they're not panaceas, and they can absolutely be used to cause harm. They can also be used in neutral ways, for recreational purposes, which I don't have any personal opposition to necessarily. I mean, I take a fairly libertarian stance around what people do with their own consciousness, as long as it's safe and they're not causing harm to other people or to themselves. I think people should have the right to explore consciousness in the ways that they see fit, if they're well-informed and adults and have the capacity to make that decision. But when we're talking about employing psychedelics to address human suffering with the express purpose of addressing something we may diagnose as a mental illness, I think that really ups the ante in terms of the safeguards and the level of care that we need to employ. And so, I don't see the medical model in opposition to other valid ways of using these substances, like for personal psychospiritual exploration, or for, in religious contexts, or, I don't see those things as mutually exclusive. But I do think that when someone is coming in with a large burden of trauma and a large burden of psychiatric symptomatology, when you're using a substance that can amplify consciousness and can amplify the intensity of a person's experience, there really does need to be a lot of skill and nuance applied, and a lot of care. And it really makes it incumbent on the therapists that are involved in that work and the systems that are employing those therapists to do everything possible to ensure that those safeguards are in place, and that people are really engaging with the work in a way that prioritizes safety. And that, I think, falls a lot to the therapist, absolutely, to create the container, and also to help the patients understand, the participants understand what they're getting themselves into. And, this idea that, particularly especially in the clinical trials, but even when this work, especially when this work is going to be, is offered, whether it's with ketamine now, and if any of these agents receive FDA approval, consent is an ongoing process. People need to be constantly, the therapists and the patients, the participants need to be constantly engaging in a process of ongoing consent around what's going on in the treatment. Because there are ways in which symptoms can sometimes get worse before they get better, and that's like I think probably one of the most controversial things that has come up, and I think it's an important thing for us to focus on and not be shy about. But it's also something I think that can be easily misconstrued or misunderstood, or can generate some justifiable consternation and anxiety in people who have reasons to mistrust therapists getting involved in this work, or who may have even been harmed by therapists involved in this work. So I think it's really important to touch on that. So I'm not sure where you would want me to start.
Yeah. Yeah, maybe just reflecting back on this topic, firstly around the FDA panel or committee, that has been the hot topic for the last few weeks since that happened. It was live streaming. It was like a soap opera kind of that day. And then articles and webinars since then. So, really seems like there's a debate happening right now, and everyone's got their opinion. And whose opinions, should be listened to the most, who really understands this complex subject. And, it's very nuanced. It's not a panacea, as you're saying. I feel like a good place to start, Casey, might be just your experience of working on the MDMA trials with MAPS like us as it is now. And particularly, any experiences there working with patients around where you were able to sense, this is why this is so effective. This is how it works. This is the mechanism of action. This is why it is different, and it helps people with PTSD, for example. So Can we just paint a picture about what we're actually talking about, how it works and why it works so well?
Sure. So I think, the place to start is with this idea of the inner healing intelligence. And maybe I'll just back up a little bit and say something that I touched on briefly at the beginning, which is, this idea that I probably wouldn't be practicing psychiatry if it weren't for these modalities. What I mean by that is the conventional psychiatric model is one that by and large uses drugs, medications that are intended to suppress or silence symptoms. So, we use antidepressants, for example, in a way that's kind of similar to how we use antibiotics in other, in infectious disease, where, there's a disease agent, a bacteria, let's say, if it's an infection, and we use a drug called an antibiotic that is intended to basically kill the bacteria and eliminate the symptoms. And a similar type of logic has been employed in psychiatry, where we'll use an antidepressant or an anti-anxiety medicine with the idea that, if a person is coming in complaining of symptoms, like the symptoms that qualify somebody for a major depressive episode or generalized anxiety disorders or anything along those lines, the way that psychiatry has evolved over, the last 50, 60 years or so is we've been trained to consider our job to be one of essentially eliminating those symptoms. If somebody comes in, they're depressed, we give them an antidepressant, those symptoms of depression will improve, and we'll keep giving the drug with the idea that it's the drug that is suppressing the symptoms, and we are achieving a cure, or getting a person into a place of remission by use of this exogenous agent of the drug. And that's we've done our job. We've done a great job if we've eliminated a person's symptoms. And, in the short term, there's certainly, that's not an unreasonable thing to believe. But what I take issue with is this idea that a person's symptoms are where the problem starts and stops, meaning because what's implied in that is a person's symptoms are a product of some type of faulty brain chemistry. And we have developed these drugs that we can take, a person can take on a daily basis to alter their brain chemistry. And by altering the brain chemistry, we are making the changes to the brain that are solving the problem, meaning the problem resides at the level of a faulty chemical milieu in the brain. And just by adjusting that milieu or adjusting the functional connectivity in the brain that underpins the patterns that we're seeing a person experience, we've done our job. And that's a nice theory, but it's in practice, it's not really what we see. What we almost always see, or what we very pervasively see, is a person will come in and they'll be given a drug like an antidepressant. It might work for a few months, a year or two, and then magically it'll just stop working. People will come in and say, this was helping me for a while, but now it's no longer working. What can I do? And the response is, because we're still employing the same paradigm of just operating at the level of neurochemicals and at the level of the brain, the response in conventional psychiatry is to either increase the dose or add another medication or maybe a third medication. And, it's very common for people to come in having tried many different medications or coming in on a cocktail of 5 or 6 medications and not achieving symptom relief. At that point, the conventional response will be to label this patient as treatment resistant, which is a kind of pathologizing way of saying that their system is basically uncooperative and not responding to the medications in the way that our paradigm predicts that it should. So the issue I take with all of that is this idea that our job starts and stops with symptoms. And for me, what I've really come to understand is that the things that we call symptoms are actually signals that are being used by an intelligent system, which is the organism, the mind, body, spirit system of the person, the human being that is coming in for help, that are intended to convey an important piece of information, which is that there is essentially an unhealed wound, psychological wound in the person that, just like if you were to injure, twist your ankle and have some type of injury in the bones, ligaments in your ankle, every time you step on it, you have pain. That's a signal, an intelligent signal from an intelligent system telling you that there is some type of injury, some type of damage that needs attention, and something needs to be modified in order to allow that injury to heal. And the symptoms that we experience in mental health conditions are no different than that, in my opinion. There's some type of injury. It's not a physical injury. Most of the time, it's a psychological injury or a psychospiritual injury. And by silencing the symptoms, we may be achieving short-term relief for a person. But if we're not conjoining that with some other type of method that is intended to get at the underlying root of the problem, which is in this case would be the psychospiritual, psychological injury, then all we're doing is kicking the can down the road. It's almost like, the smoke alarm is going off in your house, and instead of addressing the fire, you just take the batteries out of the alarm and think that you've done your job. That's, again, it may make things quiet for a little while, but the fire is going to keep burning, and the problem will resurface. And because the system itself is intelligent, you give a drug, it will maybe reduce or eliminate the symptoms for a while, but the system, as an intelligent system, will adapt and find a way to get around the thing that was silencing the symptom. So unlike a smoke alarm, our organism is very intelligent and very adaptable, and so it can change and get around the obstacles that were put in place for its signals to be heard. And so that's what I think is happening when somebody comes in and they're so-called treatment resistant. It's really, no, their system is intelligent enough to figure out ways to get the signal across, even in spite of the drug that we're using to silence the signals it was trying to give. So, so that's the fundamental difference, to my mind, of conventional psychopharmacology and what we're doing with psychedelics is the orientation towards symptoms. We're not using psychedelics as a way of directly reducing symptoms. That is obviously a very beneficial and welcome sort of byproduct of the process, but it's a downstream byproduct of the process, which is actually much more geared towards getting at the underlying psychological injuries, the trauma that underlies essentially almost the entire gamut of what's in the DSM, I think, can be considered as some type of post-traumatic syndrome. Not that it's all post-traumatic stress disorder. That is a very specific, specifically defined syndrome that you can look up in the DSM. But in psychiatry, clinical psychology, we're taught something called the stress diathesis model, which is just a fancy way of saying somebody has a diathesis, which is a way of saying that they have a predisposition, either through genetics or through their early attachment experiences, developmental experiences. They have a predisposition towards a certain type of mental illness. But what is the second necessary component of developing a mental illness is the stress, meaning some stressful event, something needs to happen in their life, which is just another way of saying some type of trauma needs to happen in their life in order to manifest either depression or generalized anxiety disorder or schizophrenia or post-traumatic stress disorder. I mean, we know this from monozygotic twin studies where two people with identical genetics will have different life experiences, and one will develop a certain mental illness, even something like schizophrenia, and the other one won't. So it's not obviously completely reducible to biology, although obviously biology has an important role to play. It's a very complex, interdependent, and again, intelligent system that's at work. So when I use the term inner healing intelligence, I am referring not to some, arcane or pseudoscientific woo kind of spiritual concept. To me, what the inner healing intelligence is, it is the actual intelligence that is embedded in our bodies, in our being, because we are more than just our bodies. We're a mind, body, spirit organism, but it's embedded in us from the genetic level on up. I mean, you can look at this, anyone who knows enough about molecular genetics and the way that DNA replicates. So, whenever a cell divides, which is, a process that's happening all the time in our bodies, the native mutation rate, in other words, the rate of copy errors, when you have a long string of DNA that needs to be copied in order to replicate and divide a cell, left to its own devices, there would be something on the order of 1 in 10,000 base pair rate of error in transcription, which would be actually catastrophic. That would be not compatible with life. But the cell in the nucleus has error correction mechanisms, proteins that will actually read and proofread the transcript of the replicated DNA molecule to reduce that error rate to something like 1 in 10 billion. So that is an incredible phenomenon that happens, and it's really not well understood. How does the cell know? How is the cell? I mean, we understand a lot about sort of the mechanisms, but the idea I'm trying to convey is that there is an intelligence embedded at the level of our very DNA that has a teleological component to it, meaning it knows somehow, so to speak, even at the cellular level, the state that is compatible with healthy functioning and well-being. That's true from the genetic level all the way on up to the level of tissues and organ systems. We have all these homeostatic regulatory mechanisms that keep us alive from moment to moment. And that is the same intelligence, as far as I'm concerned, as the thing that we are calling the inner healing intelligence in a psychedelic assisted therapy session. It's just, we're calling it has a special way of manifesting when we're talking about psychological and psychospiritual problems. But to me, it's equivalent with the intelligence that keeps us alive from moment to moment, or helps us heal a wound. If we sustain an injury to our skin or a bone or something, the body knows how to knit itself back together in a way that is compatible with well-being. So that innate capacity is what we are trying to leverage with psychedelic assisted therapy. And I think it's important to maybe get into a little bit of how that actually works. But I'll pause there, and then I just said a lot.
Yeah. Let's come up for air. That was really cool to hear you talk about, and that's why I really wanted you to come on, and particularly just to have time yourself, just the two of us, because normally we have a student here as well for a Vital Psychedelic Conversation. But the talk that you gave our students touched on this, and there's so much depth and nuance here, and it's really relevant to what the conversation is and the debate is around the FDA subcommittee, and just understanding how do we scale a new paradigm of treatment that doesn't fit in the box of the allopathic kind of symptom management pathologizing model. How do we build that? And this is, we are in that moment of history right now where we're trying to figure this out. So the inner healing intelligence potentially plays a really big part. So just one piece that you said there that I really appreciated, Casey, is that just looking at that cell, how it's almost got this corrective piece in the nucleus around the DNA. You're saying it kind of proofreads the copying errors. So it's almost like there's a quality assurance piece to this. Like I've just been working in a quality assurance policy for an outpatient addiction program in New Jersey. So I've been doing quality assurance stuff lately, and that's around, improving outcomes and safety. And so I'm feeling like part of what we're talking about is, protocols and clinical guidelines and all that stuff, and that'll get worked out. But part of this is really asking us questions around sickness, dis-ease, and this inner healing intelligence perhaps being this quality assurance proofreading voice or kind of knowingness that says, hey, my life, I need to slow things down and look at this, or things have happened to me that I need to deal with and I can't run away from it. And you were saying, typically we run away from those symptoms with medications can numb them down, or they can prove like a Band-Aid approach, but not really heal it. And sometimes I think of psychedelic assisted therapy as being when we're going into that space and kind of surrendering or kind of welcoming in and inviting it into ourselves, as understanding how does water move and work, and it always flows and it needs to flow, so it's not stagnant. It always seeks flowingness. It always seeks to go lower, to go deeper, to go just down. And I feel like psychedelics enable us and our body, soul, mind to have this opportunity to get to know each other and to go down into our own depths, into our shadow, into the levels and layers of our being where there might be some scary memories or experiences, or in a sense even transpersonal parts that we're tapping into. And how do we put that into DSM? How do we put that into clinical practice guidelines? How do we teach that? How do we put that into informed consent with a patient? This is what is going on here. So it is very nuanced. As a next question, I would like to say, so, okay, we're talking about inner healing intelligence, and it's really part of the MDMA assisted therapy protocol here. Why do you feel like it has been critiqued and criticized so much? And why is there so much, in a sense, conflict and misunderstanding, by both in the ICER report and in the FDA panel, and some of the people that were giving testimony there, really talking about, MAPS as a cult, and really, bringing kind of, flashing red lights to this needing to slow down because we're not quite ready for it yet. Why do you think some of those concerns are being broached in that way, to that kind of extreme level that we saw?
Yeah, well, I mean, for a number of reasons. One is because it's kind of a mysterious concept, or it's even though it's really baked in, as I've said, at the level of even our cellular functioning, it is still a bit of a mysterious process. And I think the other reason why there are concerns being raised around it is that it's a concept that can be misunderstood by therapists as well. And there is no getting around the fact that there have been people harmed by psychedelic assisted therapy practitioners, both in the underground and, notoriously even in the phase 2 trials. Richard Jensen and Donna Dreyer, and who were treating Megan Busson in phase 2, who later courageously came out and spoke up about her experience and the ways in which she was harmed, particularly by Jensen. They were misapplying, in my opinion, and I think in a pretty unanimous opinion of everyone I know and work with, through the phase 3 clinical trials, and Michael and Annie Mithofer and my mentors, Bruce Poulter and Marcelo Talara, all of us are very much on the same page around the idea that what was happening in that treatment is not in alignment with how this work should be done. And I think the ways in which a concept like the inner healing intelligence can be misapplied and used even to cause harm comes around this idea of symptoms needing to be sort of pushed through, or that pain or transient exacerbation of symptoms can be part of what is happening in a session, and that can get you into some potentially dicey territory if you are a therapist who is exerting a lot of top-down control in the power dynamic. And there's always going to be a lopsided power dynamic between a therapist and a participant, no matter how hard we try to, and we do try very hard to level that playing field and to allow patients to feel that they are at the center of the treatment, and that we are there to take our cues from them and to attune to them. This is a process from us of attuning to their process. There's still going to be that power dynamic, and so as therapists, we need to be constantly vigilant around that. And I can't pretend to understand what was going on with Richard Jensen, why he was and his wife were behaving in the ways that they did, but clearly something was quite off, and they were using this idea of knowing what was best for Megan, for their participant, in a way that ended up causing her harm. There's just no getting around that. There's no excuse for it. It's something that we really need to pay close attention to as a cautionary tale. We need to really honor, frankly, the sacrifice that Megan made as somebody who has brought a lot of visibility to this, the ways in which this can go wrong. So I think it's important to speak to that particular component of how this treatment can work, which is, again, this idea of, since we're not using drugs to suppress symptoms, it means we are using the non-ordinary state elicited by the medication in a particular context, which importantly involves, in the clinical trials, at least 4.5 hours of non-drug psychotherapy that's intended to create rapport and safety in the room between the participant and the two therapists. It's an opportunity for the therapist to really get to know the history of the patient, the participant well, and for there to be trust and an alliance built, and a safe container built into which a non-ordinary state can take place, with the idea of turning towards, again, the root of the problems that were causing the symptoms to begin with. And I think it's important now to understand, particularly with PTSD, let's think about what's happening there. So the symptoms that come up that define a person as having PTSD, it's a number of categories, but primary among them are what we call re-experiencing phenomena. So these can be what's called flashbacks or nightmares, basically experiences where the person is having it's not just like having a memory of the trauma, like a normal memory. It's basically it's such an intense remembrance of the experience that, for all intents and purposes, the person suffering with PTSD is reliving those experiences, right? And we can look at that And then, there's a whole amount of downstream effects from that include, numbing behaviors, avoidance behaviors, depression, the entire constellation of PTSD, I think really hinges on this core phenomenon of the re-experiencing. I think we need to think about what that is. So there's one, the conventional way of approaching that is just to say it's pathological. There's something wrong going on. The brain is going haywire. Something's broken. And so that's the way. The conventional mode is just to pathologize that phenomenology and say, this is just a symptom that needs to be removed. Another way of approaching it, which is how I would approach it, and what the idea of an inner healing intelligence would lend us to look at it through this lens, is that there's actually an intelligent purpose behind the re-experiencing. It's the body, or the mind-body isn't just creating these re-experiencing phenomena because it's broken, or because it's invested in being miserable or being in pain. It is happening in my view, it's happening for the purpose of healing. The system is trying to really re-experience the trauma so that it can be integrated and healed. Now, what happens, however, and the reason why it gets into this vicious cycle that creates a very dysfunctional pattern, is that the re-experiencing happens, but it's happening with so much emotional activation, so much fear, and just sympathetic nervous system overload is taking place at the time that the re-experiencing happens, that it just ends up becoming a re-traumatization. And so instead of being an experience where a person can, so to speak, metabolize the experience and bring it to a place of integration and wholeness, it just ends up being another iteration of the trauma. And that's what will eventually lead to a lot of avoidance and numbing and this kind of thing. And it's important to also note that not everybody who suffers what we call a Criterion A level trauma, so something like combat exposure or sexual assault, or these things, life-threatening kind of experiences, goes on to develop PTSD. And the research shows that one of the defining characteristics that distinguishes somebody who is more likely to go on to develop PTSD versus someone who isn't is what type of psychosocial support system are they coming back to in the immediate aftermath of the trauma. If they're coming back to a system, whether it's with a therapist or just family, close friends, a partner, what have you, that creates space and safety for them to engage with the endogenous, organic, naturally intelligent process that is trying to take place, which involves, allowing the nervous system to calm back down and get back to a place of safety, and also allows a person to properly grieve what happened, properly accept what happened, and, re-engage with a situation that is now safe instead of the situation that was very unsafe. If a person doesn't return to a system that allows for that enough safety and essentially love and compassion and empathy and support around them, their system is much more likely to engage in the next best thing, which is to basically short circuit and shut down in the face of the trauma. And that's the state that people will come into when they're entering a clinical trial like this, or when they're entering any type of treatment for PTSD. Their system in many ways is in this type of shutdown, or it's pendulating between these states of total overactivation when their traumatic memories are being triggered by various circumstances. They're pendulating between that and just a state of shutdown. And the shutdown tends to predominate more and more over time. And you see people just constricting their life more and more and more and more because, the external factors in the world are just become increasingly triggering, because this core wound hasn't been engaged with, or hasn't been given the proper opportunity to engage in a process of healing. And so that's an important thing to understand, that it's, if we are engaging with a person's traumatic history, or the traumatic memories that are embedded, really as through Bessel van der Kolk and others' brilliant work, we can see how it's embedded really just at the level almost of the cell or the tissue. It's in the body keeps the score. This idea, the trauma will live in a person until the system, the person, can enter into conditions that allow for healing to happen. And so And again, this is not a woo concept. This is not something that's foreign or unique to psychedelic assisted therapy. This is how any type of intervention in the entire healthcare field, whether it's medicine or surgery or psychiatry, works along the same principle. As Hippocrates said, from the Hippocratic Oath, he famously said, "The physician treats, but nature heals." So what does that mean? It means any type of health practitioner, the best any of us can do is to optimize the conditions and remove obstacles that enable the person's intelligent, inner healing intelligence to heal itself. So whether that's, an open heart surgery, you can have the most skilled heart surgeon in the world doing what they need to do. But at the end of any type of operation, the chest will be sewn back up, and the person, what will happen? They will be sent home to recover, right? Meaning they need to rest. They need to, we can give them fluids and give them nutrition and give them all the things that the body needs to do the healing. But ultimately, it's the body that needs to heal itself. Without that inner healing capacity, the success of any type of procedure that we do in medicine or surgery or psychiatry, the success rates would be zero. That inner healing intelligence is absolutely necessary for any type of healing to take place. And when we're talking about healing from trauma, as in PTSD, the concept is no different. And so what we're doing in a psychedelic assisted therapy session is, if we're doing the work well, we are creating a safe container where the person's nervous system can, and with the assistance of the MDMA, which, as we know, has certain acute effects, like reducing the level of amygdala activation, which reduces the fear response, which reduces the sympathetic overload that will typically occur in somebody who's stuck in that pattern of hyperactivation to reliving a traumatic experience. That overactivity is quelled, and it also has effects on serotonin and oxytocin, which have the effect of basically increasing this felt sense of relational safety in the room. And that also enables the person to engage with their memories and their experiences in a way that is not re-traumatizing, but conducive to healing. That is what we're doing. But what that means is a person does need to turn towards their symptoms and feel them. One of the things we say is that, it has to come up to come out, sort of thing. And it's not for the purpose of causing suffering for people, right? And it's not, this idea that's been thrown out in the media that, the therapists who work the MDMA therapy trials are some type of therapy cult, is predicated on this idea that, we're somehow, using these treatments and using the effect of the drug, which does increase vulnerability and suggestibility, right? I mean, there's no getting around that actually happens, but in and of itself, that's neither good nor bad. It can be used for good ends or it can be used for bad ends. And so it really matters who the therapists are in the room and the way that they're trained, which is why I'm personally so passionate and committed to creating systems that are properly training therapists and properly creating systems where the therapists are doing their own work. Because if a therapist isn't doing their own work, because psychedelics do amplify conscious states, and I would say that it amplifies what's present for the individuals in a psychedelic psychotherapy session, whether they're the therapist who's not taking the drug or the person who is taking the drug. The amplification happens on all sides. And so if a therapist hasn't done their own work and has shadow elements that are bringing sort of motivations into the treatment room that are not truly in alignment with what's in the best interest of the patient, then that can lead things down a dark path. And so, what distinguishes a therapy cult from the work that we were doing in the phase 3 trial is that in a therapy cult, it is expressly about disempowering the patient in the room for the gratification of the therapist. That's what a therapy cult does. It's the therapist's needs are what are being gratified in a therapeutic situation, quote unquote therapeutic situation, in the context of a therapy cult. And one could I think, rightfully argue that that's what was happening with Richard Jensen, that his needs are being gratified in that session. But I will say categorically that is not what I observed in the treatments that we were doing at my site. It's not what I've observed in the work that I've observed with other colleagues in this space. It's not what's being taught, certainly not what's being taught. What's being taught is we are constantly being instructed to check in with our own self and understand clearly what it is that we are there for, and making sure that whatever stuff is coming up for us, we are doing the work needed to get our own needs out of the way so that we can really attune and focus to the needs of the patient and really empower the participants. It's what we're doing is the opposite of what would be done in a therapy cult, meaning, the disempowering of a participant or a patient is what's really being done in a therapy cult. What we're doing is the exact opposite of that. We want to empower the patient. And this idea of the inner healing intelligence isn't some type of ruse to get them to override their own instincts or their own intuition. It's the exact opposite of that. We are explaining to them that they have the capacity to heal themselves. We are just there to help them with that process. Obviously help. We're there to support, we're there to help, where they're not doing it on their own. But ultimately, the capacity to heal is something that belongs to the patient themselves. And we are constantly trying to enforce that. And we're also, as I mentioned before, constantly assessing consent. How does this feel? Does this feel right? Does it feel right for us to do this or that? For us to explore this type of material right now in our session as we're talking, and we will ask a participant, if it feels okay, does it feel okay to go there? If so, let's do it. If not, let's go wherever you feel like we need to go. And we probably don't have time to get too deeply into the idea of touch, but that's another thing that causes a lot of concern, understandably, for people, because touch isn't a part of conventional psychotherapy. But there are ways in which a very, very judicious, careful, constantly explicitly non-sexual form of touch can be used to good effect in a psychotherapy session, such as the ones we were doing in MDMA-assisted therapy trials. And to be clear, what we mean by that is maybe holding a person's hand or putting gentle touch on their shoulder. We were explicitly instructed, unless we were given training as, body work or somatic psychotherapy, previous to our engagement in the trial, we were explicitly instructed you're not to be doing any type of body work or touch-related psychotherapy that you don't already have training and certification to do. So it's not like everybody who came into the psychedelic psychotherapy trials were suddenly expected to be doing things outside of their scope of practice or their scope of expertise. If somebody had no previous exposure to touch through their previous training, then the most that we were ever encouraged or instructed to do is something as simple as maybe holding a person's hand or gentle touch on a shoulder. Okay, so I want to be very, very clear about that too, because it's easy to extrapolate from that, or to hear the word touch, and then a person's mind will go to sort of the nightmare visions that we were seeing in that video with Richard Jensen and Megan Busson. That's there's been some suggestion that that's not an outlier case, and I'm here to categorically tell you that was absolutely an outlier case, and that type of thing would never ever be tolerated. Certainly not in any clinic that I was running, and in none of the clinics that are going to be run by any of the people that I work closely with through the phase 3 trials. So, I think that's just really important to just really state explicitly.
Yeah, Casey, thanks for deconstructing so many different related topics. Yeah, I feel like there is so much in the inner healing intelligence that we can talk about, and there is something that inherently has a sacredness to it as well, about how it operates, and that might itself be just a bit too radical for us to compartmentalize and define. There is something really sacred saying to a therapist, kind of get out of the way. Like you could well be an obstacle right now if you are doing too much or saying too much. And we talk in Vital, we use the term wait, WAIT. Why am I touching? Why am I talking? It's quite commonly known in the space. So it's really asking us, like, being very self-aware. What is my role right now? And getting out of the way of the patient, of the client, of the human being. Re-experiencing what is within. And I love how you're differentiating between the re-experiencing of trauma and stuckness and the re-traumatization of the re-experiencing, as being two different things depending on set and setting and alliance building and pieces like that. And we talk about spiritual emergence quite a lot. So I think spiritual emergence itself It is a difficult but potentially, really powerful experience. But it needs a lot of, holding, and expertise. And I feel like if it's okay, from now, maybe we could jump into the training piece of this. So we're talking about something that is very nuanced. It is a paradigm shift around training. My training as a social worker in psychoanalysis, was really like do as much as possible, like as an expert, and be really kind of hands on and involved. And I'm interested, particularly in the practicum piece here. And feel free to talk about Nautilus Sanctuary and Innermost. Because the experiential practicums, the real world experiencing of working with people that are having non-ordinary states of consciousness and having your own experiences with non-ordinary states as well as a practitioner, really, really important for just, in a sense, doing our own work and for being able to work in very foreign scenarios that we wouldn't normally get in med school or social work or psychology school. So could you talk us through maybe at a high level how you hope Nautilus Sanctuary and Innermost will work around this delivering of clinical treatment, psychotherapy and psychedelic treatment, and particularly also the training and practicum piece. So once it's kind of working at full speed, how do you see this kind of stepping into the void of what is needed really for delivering training and delivering treatment in the future?
Yeah. So I'd be happy to, and it's a big question, so I'll try and be succinct as I can. But so as far as delivering the treatment, so Nautilus Sanctuary, as I mentioned, is a nonprofit that I co-founded. Within that, there's something called the Dana Paleos Fund that is a patient assistance fund set up in the name of my late wife. She passed away in December of 2022, which is intended to create funding for essentially the subsidy of treatment for patients that don't have the socioeconomic means to pay for the treatment out of pocket. I mean, we're hoping we will be working with third-party payers, health insurance, as soon as these treatments are covered. But there'll be co-pays, and there may be a long delay before they're covered. So we're hoping that the Dana Paleos Fund will be able to serve a stopgap function, because it's also important that our therapists are well taken care of too, that they're not, their work isn't being, and their altruism isn't being exploited, because that's a good way to burn therapists out and ultimately create poor work and poor working conditions. So, it's a very tricky balance to make sure that we're taking good care of our therapists at the same time that we're taking good care of our patients, and also minimizing as much as possible, if not eliminating, socioeconomic status as a barrier to care. As I said, that's a very tricky riddle to solve, but I think it is solvable with enough effort and resources put towards it. But so on a practical level, I think that's how Nautilus and Innermost will function in tandem to get these treatments available to people. And then as far as the practicum training, yeah, I mean, there's plenty of good didactic trainings on psychedelic assisted therapy. Vital is one of them, but that's only going to get a person so far as really getting the chops of how to do this work. There's only so much you can learn, in a didactic setting. You really also need to put it into practice and kind of learn on the job through the practicum training experiences. And so what we intend to do is to use the treatments that we're delivering to patients in real world clinical settings, as practicum training cases for people to learn in a sort of apprenticeship model. They'll be either paired with a senior, more experienced therapist, or if it's two less experienced therapists, they will have a lot of oversight through video recordings and the like, about what's going on in the room. And so, it'll be a lot of supervision, either directly in person or through video, that will inform the supervision process, and allow a person to learn in real time from what is happening. Obviously with the emphasis placed on making sure that the treatments are being delivered safely. We're going to have to put safeguards in place around that too. And so it's going to really, I think, hinge on the type of culture and community we can build, and how much we can really cultivate sort of a culture that is rooted in striving towards excellence, that is rooted in humility. I mean, I would say the number one important character trait of somebody who is going to be a good psychedelic assisted therapist is humility. Humility in the face of what we don't know, humility in the face of the patient's autonomy and their inner healing intelligence, and in this sense that you named it for, which is this the sense of sacredness that does enter into these sessions. There's that's a loaded term, which people can sometimes be allergic to, but I think there is a sanctity, a sacredness to this work that derives from the fact that there is this intelligence that exists in the world that is non-linguistic, non-verbal, non-conceptual, and yet very powerful. We see it in the natural world all around us. I mean, just walk through a forest that, just looking at the ways, the more we understand about how nature works, from the microscopic level up to the level of, an ecosystem or our entire planet. I mean, just the amount of harmonious complexity and beauty there that's expressed there is, to me, sacred, right? And it gets expressed at all levels in this sort of fractal way, from the very microscopic all the way up to the level of the entire ecosystem. There are these incredible emergent properties that come up in ways that just are frankly magical on some level. We can understand it. Just because we can analyze and understand it doesn't mean it's not a miracle. Life is a miracle. The fact that anything exists at all is a miracle. We don't have a good explanation for why anything exists, let alone why the things that exist are ordered in this incredibly beautiful and almost mystical way. As Einstein said, the most incomprehensible thing about the universe is its comprehensibility. The fact that there are these systems that obey these comprehensible laws is incomprehensible on some level. That's what I mean by saying that it's a miracle. I mean, Einstein also said there's only two ways to live your life, as though nothing is a miracle, or as though everything is a miracle, right? And I really do believe that, which isn't to put things into the realm of the supernatural or woo. I mean, we also have the miracle of our ability to analyze and comprehend reality, and but then there's a balance that needs to be played there, because there's ways in which our analytical intelligence, our reason, can reduce things, with important consequences and to good effect, but that creates a map of abstractions that obviously corresponds in important ways to the territory, to the world at large, but is not equivalent with it. And so we need to constantly be humble in the face of that discrepancy, the fact that our maps of the world are not the territory. There's a famous statistician who once said, all models are wrong, but some are useful. So that's another thing that I find very important to remember, that every model, every map that we have of the world is provisional, and at best can only really asymptotically approach the truth of how things are. It'll never fully get there. And there will always be that sort of essential element that's kind of left out of our reductive analyses, and that's okay. It doesn't mean we should throw away the reductive analyses, but we should have proper humility and know that the reductive analyses will only get us a partial glimpse of the truth. And so, it's important to incorporate multiple different ways of approaching a reality to get a more holistic sense of how things are. So, science and mathematics is one really powerful and beautiful way of approaching it, but so is poetry and art and dance and all of these other ways of expressing and being in the world. Those also communicate a form of truth. It might not be quantifiable, but it doesn't make it any less real or any less impactful or important. So I know I've gotten way off of the on a tangent away from practicum training, but what I mean to say is, like, for me, what I want to do with Innermost is create a culture that really celebrates the multiplicity of approaches, and celebrates different specialities within mental health and health more generally, and see how we can learn from each other, from our different approaches and our different ways of viewing the world. I think those can be complementary and really beautiful, rather than having a system where only one form of the truth or one form of examining the truth is given validity and all others are thrown out. I think, there's a way in which we've become very overly reductionist in our culture and in our society and in our profession. And I want to create a place where we're celebrating diversity on all levels, personal diversity, different personal backgrounds. I think it's important for people, for the people who will form our organization to come from a very diverse background, both on an individual person level and on a professional training level, so that we can really enhance the work that all of us are able to do. So, but ultimately, at the end of the day, what truly matters is what type of experiences are our patients having? How are we keeping them safe? How are we optimizing the conditions for them to heal? How are we empowering them? How are we celebrating their autonomy, and putting them in the best position to heal from the traumas that are brought them in, seeking help, and orient themselves towards the pain and the suffering inherent in those traumas in a way that actually is conducive to growth and increasing connectedness and expansion of self, as opposed to the constriction and the isolation that can happen when those wounds are unhealed. There's a lot I could say, which I probably don't have time to around the real central importance of suffering and how we orient ourselves towards suffering in terms of human flourishing, not just healing from trauma, but also promoting human flourishing and self-actualization and human potential. I think it all really hinges on the way that we exercise our free will to respond to pain and suffering in our lives. The pain and suffering is inevitable, but we have a choice regarding how we orient ourselves to it. And, sometimes the choices are made for us because of the way our nervous system reacts to pain and suffering. So that's where sometimes more interventional types of approaches, like a psychedelic assisted therapy or a psychotherapy in general, might become necessary. But ultimately, what I perceive my role as a therapist to be is to help my patients create enough space between the stimulus, the painful stimulus, and the way that they're responding to that stimulus, to exercise greater degrees of choice, so that they can choose to respond in a way that is conducive to growth, as opposed to conducive to greater isolation and disconnection. And yeah, so, I have a lot more that I could say about that, but maybe for another conversation.
Yeah, you're welcome back, Casey. That was really awesome. I think there's one thing or two things maybe that's bringing into my mind. We're talking about, I guess, logotherapy and Viktor Frankl that we've spoken about before, and that quote that suffering ceases when it finds meaning. And in the last cohort of Vital, cohort number 2, there was one of our students in her final presentation was showing, like, this is my brand, this is my protocol. And we're talking about protocols here in some sense, what works and fidelity to the protocol, and you've got to be 100% compliant and 100% fidelity. And I think for you, and I'll come back to this student I'm thinking of, for Innermost, it's a center of excellence, and you're coming in there, talking about protocols and, keeping things very safe, responsible, and ethical. And at the same time, I'm sensing it's a community hub, and there is room for creativity, exploration, and iteration for local needs, filling a gap there. And so we had this one student last year, and her presentation was using the Japanese art of, I think it's pronounced kintsugi, where you've got the broken pottery, you smash it, you refix it up with gold. Yes. So that's her model. So she'll work with a client and start doing therapy, build the alliance, and then before sessions, they will break a piece of pottery in a bag and then have their non-ordinary state session, and then come back, and the integration is, okay, let's open that bag and rebuild this pottery, with gold, and that's like the disintegration of self, ego, shadow, and then the reintegration of it. And there's no fidelity to any protocol or REM strategy or clinical practice guidelines where everyone's piece of pottery is going to be exactly the same, the same kind of gold that needs to be put in it. So we need these centers where clinicians can have the confidence to work with clients in an authentic way, so we're not robots. And I worry sometimes that we're all going to become robots with artificial intelligence, tracking every word that we say, what our intonation was of our voice, what our body language was like, and our eye contact, and did we lean over in the right way. So I do worry there's just too much oversight around therapists, and our own skill development. There's a space for it in training, definitely recording sessions. But there's something really beautiful about intuition and iteration, and working with our clients in a way that only they and we can enter into together in that somewhat sacred therapeutic alliance there. So Kintsugi really helps me feel into that, and as a center of excellence, it feels like Innermost is gonna give us the confidence and the competence and safety to kind of explore how we evolve into being competent, ethical psychedelic assisted therapists. So just maybe as a final thought, anything there you want to just riff off, Casey?
Yeah, no, that's really, really beautiful that you bring that up. Also kind of synchronistic, because my wife, before she passed away several years before, she had a project that she wanted to do. She wanted to create a book called Sacred Scars, based on this idea of kintsugi, which is, this idea of more beautiful for having been broken. So the pottery is broken, as you say, and then, in the artwork, there's gold, kind of gold paste that is used to glue the pottery back together, and it's a more beautiful piece at the end of that process. And so she wanted to create a book. She had gone through a number of surgeries, and she wanted to work with a photographer, with herself and other people who had this types of marks from illness, and have it be sort of digitally manipulated, or maybe with body paint to look gold, and then tell a person's story with each photograph, series. But that never came to fruition. But maybe someday. But yes, at this idea of allowing for creativity, allowing for that uniqueness, allowing for the human element is so necessary. And so I think what I want to try and build with Innermost is a place where there's certainly all the structure and oversight that is needed to keep patients and therapists safe and to keep the work at a high quality level, but we're not building, a manufacturing plant. We're not trying to create widgets. There's a lot of uniqueness. I mean, this is what makes this work so rich and rewarding and fulfilling is that uniqueness. Every human being that comes in is a unique, utterly unique. They will never, their experiences, that person will never be replicated again in the universe. And so that's what makes this so compelling, and also challenging too, because we have to be adaptable. And this is why, as I said before, the real central role of the therapist in the room for psychedelic assisted therapy, I mean any type of psychotherapy, but particularly psychedelic assisted or MDMA assisted, is one of attunement. It's almost like I've found myself musing when we're really in flow in a psychedelic therapy session, MDMA therapy session. It feels like we're creating jazz music. It's like each person has their own instrument, and we're just sort of spontaneously tuning into one another. The participant is the one that's driving the melody, but we are also there contributing our piece. And it's not a non-directive approach. That was a term that was used in the early days of the MAPS protocol. They changed it while we were sort of in the midst of the first phase 3 trial into actually inner-directed approach. So, which is more, I think, has greater fidelity to what we're actually seeing, which is it's not that we're totally quiet, silent, not saying anything in the room. We are gently being directed at certain places within the therapy, but it's always in response to something. It's an amplifying something that the participant is bringing up and out. We're not. We want to be very careful that we're not imposing our own interpretation, our own way of thinking how things should go. It's always about attuning to what the person is bringing in spontaneously with the assistance of the non-ordinary state that they're in, and just, helping them amplify and deepen it. Again, with a constant process of consent, does it feel okay if we talk a little bit more about this, or for you to maybe quietly close your eyes and focus on this and see what comes up. And if a person says, no, it doesn't feel okay, then we don't push it. But that's the ways in which we're directed. We're directive through a process of attuning to the inner directed sort of intelligence that we are observing in the room in these states. And so, and so there's a lot of creativity that goes into that. We have to be a musician or to be creating spontaneous art like that. You have to be creative, and you have to have the flexibility to, to be spontaneous and allow the spontaneous things that can emerge to emerge. And sometimes it can be playful, and sometimes it can be very heavy and thick, and and it can run the gamut amongst all of those things across all that entire spectrum. But there is a lot of creativity in this work when it's being done well, but a person has to learn the real basics first. Like, you can't become an improvisational musician before you learn, the basics of the scales and like how to actually do the basics on the instrument. So that's definitely something we want to teach. And then we also want to really empower people to be creative and improvisational, and encourage their participants and their patients to sort of engage with that creativity within themselves, because that's really where the magic happens.
Beautiful. Yeah, fundamentals, foundations first, and then kind of improv and iteration. Casey, this has been a joy. I wish we had another hour, but I know we've got a hard stop. So before you go, just a big thank you. And if you can tell folks that are listening and watching, where should they go to find out more about you and the projects that you're working on?
Yeah, thank you, David, for having me. It's been a real pleasure being here. It's been a pleasure teaching the courses. I'm looking forward to opportunities of doing that in the future. And as of right now, so people can go to nautilussanctuary.org. That's the only active website. We're in the process of creating a website for Innermost PBC. It's a very new organization, so we don't have a website yet. But website that is active right now is nautilussanctuary.org. Although that's also a little bit of work in progress, but it is live, and people can go there, and we have a mailing list that people can subscribe to if they're interested as well, that they can find at the homepage of that site. So it's Nautilus Sanctuary, all one word, .org. And I look forward to continuing this conversation with you some point down the line.
Yeah, until the next time. Casey, thank you for being at the cutting edge of the clinical, the scientific, and the sacred and the numinous. It's lovely to hear you speak. Thanks everyone for listening. Have a great day. Cheers, Casey.
All right, take care.